In this video, we will explain how to correctly measure new or enlarged T2 lesions in patients with multiple sclerosis. If you want to avoid a common pitfall measuring new or enlarged T2 lesions, then you should watch this video. Why are new or enlarged lesions important? Disease activity in patients with MS classically has been defined by the occurrence of new neurological symptoms or by the rate of relapses. If patients are regularly scanned with an MRI, disease activity can be detected much earlier, even if the patient does not show any neurological symptoms. So new or enlarged T2 lesions found on the MRI, and this is what we also call lesion activity, can serve as a surrogate marker for clinical disease activity in patients with MS. This is also the reason why lesion activity is an important endpoint in many clinical MS drug trials. In clinical routine, lesion activity is used for treatment monitoring. If lesion activity is identified on the current MRI, the current treatment might not be optimal and a change in therapy regimen might be an option. How do we practically measure lesion activity? Based on our experience, there is often a misunderstanding in the way how to measure lesion activity. Let's have a look at a concrete example. Here we see the baseline MRI scan of an MS patient. At baseline scan, 27 lesions were identified. Now, 1 year later, the follow-up MRI is acquired, and 24 lesions have been identified. Now, it is very tempting to conclude that 3 lesions must have disappeared. However, in this case, in fact, there are 4 new or enlarged T2 lesions. At the first glance, this seems to be strange. There are 3 reasons why lesion activity cannot be measured by counting lesions independently at baseline and at follow-up, and then simply to calculate the difference between their numbers. There are 3 reasons. The first reason is that lesions can appear, as shown in this example. They can also disappear, as shown here. This is the same patient. The second reason is that lesions can grow together or become confluent. So here at baseline, we see 2 disjoint lesions, and at follow-up, 1 lesion has grown and it became all 1 bigger lesion. The third reason is the rate of variability. What do we mean by that? Here we see an example of a large confluent lesion at baseline and at follow-up. You probably would agree that there is not really a big change or difference in dead lesions between baseline and follow-up. However, in that case, an experienced rater counted the confluent lesions at baseline as 3 independent lesions. 1 year later, the same rater, without looking at the baseline scan again, counted the lesion at follow-up as 1 bigger confluent lesion. Both ways of counting lesions is probably okay and correct. It just shows that there are cases with ambiguities and where different possibilities of counting lesions is possible. Here's another example where at baseline a confluent lesion was split into several small lesions, and at follow-up the same rater counted the same lesion as 1 bigger lesion. Now let's see how to quantify lesion activity in a more meaningful way. What is very important to directly compare the follow-up and the baseline flare side by side. To facilitate the comparison, we align the baseline and the follow-up flare via some image registration. A new T2 lesion is now defined as a lesion visible at the follow-up scan, which is not visible at the baseline scan. If a decision based on the flare is not possible, for instance, in the inferotentorial region of the brain, the follow-up T1 should be used as a confirmatory sequence. In this case, the follow-up T1 need to show a corresponding hypointense signal at the same location. If direct comparison between baseline follow-up and enlargement need to be unequivocal, that means it must be certain that the enlargement could not have been caused by a variation of image acquisition, like the angulation, artifacts, or image contrast. Here you see the configuration of the MRI viewer we use to identify lesion activity. On the left side, we display the baseline flare, in the middle, the follow-up flare, and on the right the follow-up T1. All images are aligned, and the interactions with the images, like scrolling, zooming, etc., are automatically coupled, so that we always see corresponding slices. We also use a toggling functionality between baseline and follow-up flare. In this way, changes between baseline and follow-up are nicely visible as a flickering signal, and even very small new lesions can be detected easily, as shown here in that example. As we have seen, to measure lesion activity requires quite some manual work and is usually very tedious. Fortunately, computers can help and save a lot of time. We have trained a convolutional neural network. The baseline and the follow-up flare were simultaneously processed by the network, which was trained on more than 3,000 images. And we demonstrated that the CNN enables to automatically identify lesions activity in less than 1 minute with an accuracy which was within the inter-rater variability. With this slide, we would like to conclude this video. Let's summarize. Lesion activity cannot be measured by counting lesions at baseline and follow-up independently. The follow-up and the baseline flare need to be compared side by side. For difficult lesions, for instance infratentorial lesions, the T1 image should be used as a confirmatory sequence. Automatic methods using deep learning can save a lot of time finding lesion activity. If you are interested, please contact us or download our recent publication. The link can be found under this video. Thank you for watching this video.